the inclusion of people into a group can always be a little disruptive in the beginning because you have to make more seats at the table, but much more so disruptive in a mutual sense. The people you invite to participate has to see a good reason for their participation. And at least in America, where most patients are cared for by fee-for-service type of a model, time is the most valuable commodity. And so for pulmonologists to go to a multimodality meeting group and to participate, he or she must feel that they can get some worth out of it for the patient and also personally into their practice. And as such, having, I think, a routine flow of the patients, knowing when they would go to the pulmonologist, either for diagnostic, so-called minimally invasive diagnosis, such as bronchoscopy, lymph node staging, and when perhaps to get the pulmonary function, will give them a vested reason, so-called to be a interested member or someone who is a positive stakeholder. And very often, I think groups tend to have a bit of a zero-sum game feeling. A surgeon may say, wow, if I give up the median stenoscopy for a lymph node to the pulmonologist doing a bronchoscopy, then I have lost out. But the truth is that's not quite the case, because with multimodality therapy, more and more patients are actually now getting so-called induction or upfront neoadjuvant therapy if we diagnose a stage 2 or stage 3 lung cancer. And if they do well, why then in fact that increases the pool of patients eventually going to get surgery. And if they don't do well and they have progression of disease, then we know they should not have undergone surgery in the first place. And I think that's very important, because after all, the primary focus should be on the welfare for the patient.